start now.
Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation, continuous medical education online meetings. We are pleasure today to have Professor Hafez Bazaraa, Professor of Pediatric Nephrology, as a speaker, one of the eminent pediatric nephrologists and professors of pediatric nephrology in Cairo University as a speaker. And we have Professor Fatina Fadel, the head of Pediatric Nephrology Department in Qasr Al Aini Nephrology, Qasr Al Aini Nephrology, Pediatric Nephrology Center, and Abu Rish Hospital. And Professor Ahmed Al-Qurai'i, Professor of Nephrology and Internal Medicine, representing adults in this session as moderators, two moderators of this hot, interesting topic. I would like to welcome all our attendees and all our attending professors in this session, and leave the floor to our moderators to take over and to start our lecture today about Oxaloria. Please, Professor Fatina and Professor Ahmed, start.
Yeah, okay. Good afternoon or good night. We are late now, everybody. It's my pleasure to share this very important session about primary hyperoxaluria. I would like to thank Professor Yasser very much for choosing this topic, which is a very important and hot topic. It's more related, I think, to the pediatric age group. However, I think it's also related to adulthood cases. I think you see, especially primary hyperoxaluria type 2 and 3. Dr. Hafez is going to speak about all types of primary hyperoxaluria and all the intervention which would help in the diagnosis and treating such important issue. I'm once more thanking Professor Yasser for choosing this topic, and I am honored to have Professor Ahmed Al-Qurai'i with us sharing, moderating this session. Actually, it's this disease has a genetic background, and I know Professor Qurai'i is interested in the genetic part of nephrology diseases. So I think this topic will fit with his تطلعات دكتور أحمد في coming إن شاء الله era. So I will leave the talk for Professor Ahmed, and then Professor Hafez is going to present his talk.
Excuse me one second, Professor Ahmed and Professor Fatina, to thank our moderator today, Dr. Islam Abu Ni'ma, for his work and for his coming work over the coming days for this lecture. Thank you, and please, Professor Ahmed.
جزاكم الله خيرا. بسم الله والحمد لله والصلاة والسلام على رسول الله. Much obliged for the introduction from Professor Fatina, as well as our dear host, Professor Yasser. Thanks, Dr. Islam, for your efforts. And I'm very honored and pleased to be with Professor Hafez in his introduction today to primary hyperoxaluria and oxalosis. Actually, yes, it's both adult and pediatric nephrology interest, and it's a very nice start for the common practice that we have to share all together between adult and pediatric nephrology. And definitely these genetic or nephrogenetic background diseases are being much and more prevalent within our adult population of nephrology diseases, as well as being more, let's say, recognized and more understood, as well as with the potential for more treatment, and maybe primary hyperoxaluria is starting its relation from the nephrogenetics, starting from the initial diagnosis throughout the clinical finding to the subtyping of the disease, which would affect the choice of the treatment, including whether or not to transplant the patient, and then even through the genetic treatment that is available now in the market with the silencing RNA. And we are really looking forward to hear a very interesting topic from Professor Hafez, and very interesting, inshallah, interactions between the attendees with the presenter at the end in the discussion part. Thanks again for everyone. And the floor is yours, Professor Hafez, for your very interesting lecture.
Assalamu alaikum. Thank you, Professor Ahmed, and my Professor Dr. Fatina, Dr. Yasser and Dr. Islam, Professor Yasser and Dr. Islam. And it's my pleasure to be with you today for this topic. And after the interesting introduction by Professor Ahmed, we are going to talk about primary hyperoxaluria or hyperoxaluria. And we can start by this scenario, and this is a real case, a real patient we had. He's been a 4-year-old boy with recurrent abdominal pain, kidney and ureteric stones, bilateral, ultrasonography showing small, highly echogenic kidneys and moderate hydronephrosis, and a serum creatinine of 5 milligram per deciliter, anemia, and other features of advanced CKD. This patient has been diagnosed and genetically confirmed to have type 1 primary hyperoxaluria, and soon started renal replacement in the form of regular hemodialysis. What happened for this patient is that he had received a simultaneous combined liver and kidney transplant in year 2010, that's 13 years ago. And following some events, you know, this is a quite extensive procedure and has been done at a quite young age. And there have been some hurdles in the early post-operative and follow-up phases. But now, 13 years after the procedure, he has fully functioning graft and both renal and liver grafts with essentially normal creatinine. He's now, he should follow with our adult nephrology professors. He's now over almost nearly 20 years old. And the patient is doing quite well with normal growth and a very good quality of life. Now, the other story, or the alternative story, which we don't like, would be that same patient with primary hyperoxaluria, renal stone disease, progressive CKD, and end-stage renal disease, and would have been transplanted as the treatment of choice for end-stage renal disease, received a kidney transplant, and a few weeks later, developing a rising creatinine, for which a biopsy would have been done and would have shown no evidence of rejection, but dense oxalate deposits with an early aggressive recurrent primary hyperoxaluria and renal graft loss. This is the scenario we don't like to see at all. Now, this is oxalate, and oxalate is both exogenous and endogenous. In the human body, oxalate can come from foods and as well from metabolic pathways, primarily in the liver. And oxalate has no real well-defined use for the human body and is ultimately excreted by the kidneys. What we can see now are oxalate crystals. And many times when looking at urine reports for any reason, we can find positive oxalate crystals, and that does not necessarily denote primary hyperoxaluria. Oxalate is a rather insoluble substance, and calcium oxalate salts can easily form into crystals, and these crystals, given the right circumstances, can develop into stones. 12% of the population worldwide could develop renal stones at some point in their lives. And stones result from the combination of supersaturation, which means a salt concentration that exceeds the solubility limit of that solute in the fluid, in this case urine, allowing it to start to crystallize. And following anidus formation, these crystals can accumulate and form stones. However, as everything in our body, as the coagulation cascade, as the complement cascade, there are natural inhibitors. There are crystallization inhibitors, like, for example, citrate, which inhibit the progression of this process into stone formation. Of course, we know this, but we can review it together. 80% of renal stones are calcium salts, calcium oxalate and calcium phosphate. Other types include the Strovite stone, which is the magnesium ammonium phosphate, and that's related to infections, and the uric acid and cysteine stones, which can be associated with other metabolic derangements beyond the scope of our talk today. So what's hyperoxaluria? Basically and simply, it's increase in urinary oxalates. When the concentration of oxalate in the urine increases, that's hyperoxaluria. And there are certain foods which are rich in oxalate, as shown in our slide. These foods can increase the amount of oxalate in the human body, and therefore it will normally be excreted in urine. However, there are a number of causes of what's called secondary hyperoxaluria, which are mainly related to increased oxalate absorption from the gastrointestinal tract, sometimes increase in oxalate precursors, like excessive amounts of ascorbic acid, for example. And we have bacteria. We are normally living with a large number of bacteria that represent our microbiome, and certain bacteria can use oxalate for energy production, and therefore disturbance in the bacterial or the microbiome can sometimes be associated with hyperoxaluria. You know this person? This is Garrod. Archibald Garrod is the first who described the theory of inborn errors of metabolism. And that was over 100 years ago. And according to Garrod, we inherit certain enzymes, and these enzymes catalyze reactions that convert substrates to products. And if this enzyme is absent, we are going to have a problem in which the substrate increases, the product decreases, and maybe the extra substrate would go to another pathway, producing another product, which can sometimes be toxic or injurious. Primary hyperoxaluria has been first described in 1925, almost 100 years ago. And primary hyperoxaluria refers to increased amount of oxalate in the urine associated with increased endogenous oxalate production associated with genetic enzymatic defects in the oxalate metabolism pathway. The reported incidence has been highly variable, ranging from few per million to 1 per 58,000. And in countries like Egypt, where consanguinity is relatively still common, we expect the incidence to be quite in the high portion of that range. They are genetic autosomal recessive disorders with increased endogenous production of oxalate as a metabolic end product, which is then excreted in urine, leading to primary hyperoxaluria. Here we can see some of the reactions associated with oxalate metabolism. We can see that hydroxyproline is metabolized into the mitochondria to hydroxyoxyglutarate HOG, and this HOG is normally by the enzyme hydroxyoxyglutarate aldolase HOGA is metabolized further to pyruvate. Now, if this is blocked, we are going to get increase in a substance called glyoxylate, and that's the precursor of oxalate, and this condition is known as primary hyperoxaluria type 3. Glyoxylate is metabolized to glycolate, and that's by GRHPR, glyoxylate hydroxypyruvate reductase. And this enzyme, when deficient, we get a disorder known as primary hyperoxaluria type 2, because glyoxylate will not be metabolized. It will just come out of the mitochondria in the hepatocyte cytosol, and it is the precursor of oxalate. Normally, glyoxylate is converted to glycolate. Glyoxylate and glycolate enter the peroxisomes and are metabolized by the liver-specific enzyme, alanine glyoxylate aminotransferase, AGT, and it is metabolized to glycosylate and then to glycine. Now, the first reaction, glycolate to glycosylate, is catabolized by glycolate oxidase, GO, and remember this enzyme is going to be very important later on in our talk. And then comes the role of AGT to convert the glycosylate to glycine, and glycine is an amino acid that's present everywhere in the body and is used as a protein building block, and as a neurotransmitter we have no problem. But if there is a block in number 4, the AGT enzyme, we'll get type 1 primary hyperoxaluria with accumulation of glyoxylate, which is again the precursor of oxalate. So in this diagram, we can see 3 pathways for overproduction of oxalate. The first one, primary hyperoxaluria 3, associated with step number 1, associated with the HOGA enzyme. The second one, primary hyperoxaluria type 2, which is associated with GRHPR in the conversion of glyoxylate to glycolate. The third one, or maybe should be the first one, because this is the most common, the most severe, the type 1 primary hyperoxaluria due to AGT, alanine glyoxylate aminotransferase deficiency. And here we need to take note of 2 enzymes, which will prove very important later. The first one is the GO number 3, the glycolate oxidase, which converts glycosylate to glycolate to glyoxylate. And the other one is the LDH number 5, which is the step responsible for converting glyoxylate, the oxalate precursor, to oxalate. So we have 3 defined genetic types of primary hyperoxaluria. Type 1, due to alanine glyoxylate aminotransferase deficiency or mutation, and it represents 70% of cases, and it is associated with end-stage renal disease virtually in 100% of cases, but it can be at different ages. It can range from infancy till adulthood, and the disease spectrum is widely variable, as we're going to see. Type 2 associated with GRHPR mutation, and it represents 10%. There is no infantile oxalosis, but approximately 1 in 4 patients could reach end-stage kidney disease. Type 3 due to hydroxyoxyglutarate aldolase, HOGA1, and this represents about 10% of cases, and it's the mildest of the 3. Only a few patients have been reported to receive kidney transplants for end-stage kidney disease, although early childhood onset nephrolithiasis has been reported with this disease. Of note that 10% of cases are associated with yet unidentified mutations. That means they are negative for the AGT, GRHPR, and HOGA mutations. The type 1, there are more than 200 described mutations, essentially all develop end-stage kidney disease. And even when they develop end-stage kidney disease, those with end-stage kidney disease due to primary hyperoxaluria type 1 have threefold the mortality of other patients with end-stage renal disease that's not due to primary hyperoxaluria type 1. To add a little bit to this, no dialysis can sufficiently remove oxalate. You cannot remove the amount of oxalate overproduction by any known dialysis modality so far. And if the patient receives a kidney transplant, recurrence is common, almost universal, and can be early and can lead to graft loss. So that's a devastating disease, but it does not have to remain so. And we can see this later on. Early manifestations of primary hyperoxaluria are going to be mostly related to nephrolithiasis, urolithiasis, and nephrocalcinosis. Increased urinary oxalate can be also associated with obstructive uropathies, can be associated with calcium oxalate deposits in the renal parenchyma, which we call nephrocalcinosis, and can be associated with tubular toxicity and inflammation. And this is going to become very important later in our presentation. But those three factors, the stones and obstruction, the nephrocalcinosis, and the tubular toxicity and subsequent inflammation are going to be associated with progressive renal damage. And when the kidney function becomes impaired, remember, oxalate used to be excreted in urine and it doesn't go anywhere else. So when the kidney is no longer capable of excreting that oxalate sufficiently, it's going to accumulate in the blood and go to the tissues, and we get what's known as oxalosis, which refers to tissue oxalate depositions as a result of someone with primary hyperoxaluria developing significant renal impairment, maybe CKD stage 4 or 5, or GFR below 30, and that causes what we can call hyperoxalemia and tissue deposits, and the tissues can take quite a lot of oxalate, and we can get bone disease, we can get ocular retinal oxalate deposits, we can get skin lesions, we can get bone marrow infiltrates with cytopenias and extramedullary hematopoiesis with splenomegaly and so on, and we can get cardiovascular depositions which can result in endothelial dysfunction and cardiac complications, just to name a few. Primary hyperoxaluria has a broad disease spectrum, starting from an infantile form with early nephrocalcinosis, and we're going to define infantile form as reaching the need for dialysis before the age of 1 year. And this condition is going to be very aggressive with widespread oxalate deposits, and we all know the difficulty of providing any form of renal replacement in these patients. And this form represents about 1/3 of cases of type 1 primary hyperoxaluria. A more modest form, so to say, is recurrent nephrolithiasis with progressive CKD that can reach end-stage kidney disease during childhood, adolescence, or adult life. The late onset form can present with recurrent or bilateral stones and progressive chronic interstitial nephritis and CKD at a later age. Some patients are diagnosed by screening, by family screening, because this is an autosomal recessive disorder with 25% sibling recurrent risk, sometimes prenatal diagnosis, and at-risk pedigrees when analysis of the pedigree suggests a genetic cause in someone with stones, or even in a pre-symptomatic, a completely pre-symptomatic patient, we can detect it. And the unfortunate 10% who are diagnosed with recurrent post-kidney transplantation, and this can cause unexpected and unpredictable and catastrophic graft failure. And because of the variability in the presentation, it has been supposed that there may be a role for modifiers that can change the severity or the phenotypic expression of the mutations, whether they are genetic, renal, or genetically determined renal factors that can modify the disease severity. So how can we diagnose this condition? The most logic issue is we're talking about primary hyperoxaluria, increased urinary oxalate. So we are going to measure urinary oxalate. The recommendation is to collect 24 hours and measure 24-hour urinary oxalate. In pediatrics, we don't like 24-hour collections much because of difficulties and incomplete collections and so on. So we tend to use spot samples like we do for assessment of, for example, protein excretion rate by spot protein creatinine ratio. We can use spot urine oxalate creatinine ratio, but note that the normal ranges differ by age. There is a very important precaution that we know oxalate can exist in urine as calcium salts, and these are not very soluble. So the urine has to be acidified. Otherwise, we are going to have oxalate deposits in the urine sample, which will not be detected when measuring the amount of oxalate in the liquid phase of urine in the lab. So the samples need to be acidified. Alternatively, they can be refrigerated and the lab is going to acidify them, but it has to be within 24 hours. And 2 positive results are generally needed to diagnose hyperoxaluria. And these are the norms, the age-appropriate norms for 24-hour urinary oxalate and for urinary oxalate creatinine ratio in different ages. The second thing we might do is measure plasma oxalate. A word of caution, plasma oxalate has no value if the GFR is above 30, because when the kidney is functioning reasonably well, the oxalate is going to be excreted in urine and plasma levels might not be elevated. The second issue is that plasma oxalate needs to be interpreted relative to GFR because severe renal impairment in patients without hyperoxaluria can be associated with somewhat elevated plasma oxalate levels. The third issue is that there is a wide variation in the cutoff. Values have been reported ranging between 6 to 18 micromole per liter as cutoff levels for plasma oxalate. I think you've got my feeling that this is not a very nice test to do. The third thing is enzyme activity in liver biopsy, and this used to be done before widespread genetic studies. Now we know that we are looking for mutation in one of 3 genes, and therefore targeted gene sequencing can have a role in the diagnosis or confirming the diagnosis of primary hyperoxaluria. So if you have a patient with renal stones or nephrocalcinosis and a GFR below 30, that's CKD4, or an age less than 18 years, regardless of the GFR, or recurrent stones even in an adult, you might consider doing urinary oxalate measurement, and urinary oxalate measurement can be of value when the GFR is above 30. If it's below 30, plasma oxalate can have a role. You may need to exclude enteric hyperoxaluria, and you may need to immediately initiate conservative measures and vitamin B6. We'll come to that later. Once suspected, you can give them. There is no real harm from them. But now, when we are needing confirmation, or maybe earlier when we are seriously suspecting, genetic testing should be of value, because genetic testing, as I've said, we can target the 3 particular genes we're looking for in our patients. There is a diagnostic dilemma. As I've said, the disease has a very wide spectrum. In young children, stones are not as specific as they are in adults. Adults with stones generally present with symptoms that can be attributed to the urinary tract: loin pain, hematuria, dysuria, renal colic. However, young children with stones can present with just unlocalized abdominal pain, unexplained crying, and you must look for them. Transplantation recurrence risk has often been underestimated. I don't mean by this we don't know it recurs, but I mean some cases are first diagnosed after transplantation, as I've said in the disease presentation before. Stone analysis and the presence of oxalate crystals, of course, there is a lot of work on studying stone morphology and stone composition and the value of calcium oxalate monohydrate in specific patterns that suggest rapid formation of the stone and associate this with primary hyperoxaluria. However, it's not really specific or easy to be done. Urinary oxalate is not available everywhere, and it's inaccurate with low GFR. Non-renal tissue load, if you're going to look for oxalate in the bone marrow or oxalate in the extrarenal tissues, that's too late to be of value, of course. And plasma oxalate is many times not available and not standardized. And all these favor the role of genetic study in the diagnosis of primary hyperoxaluria. Last, we come to the management. And the management revolves around 5 main elements: conservative management, urological interventions. Patients might have stones causing, for example, urinary tract obstruction and may need endoscopic urological interventions. Of course, we cannot follow every single stone in a patient with primary hyperoxaluria. The stones can be too many, but if it's causing a complication, it will need urological intervention. And the imaging and intervention recommendations for primary hyperoxaluria are quite the same as the interventions recommended for stones causing obstructive uropathies otherwise. And then we have the renal replacement. As we said, it's a progressive disease, more universally and more rapidly with type 1, but possibly with type 2 as well. Liver transplantation can have a role. And lastly, novel and emerging therapies. Conservative management basically consists of aggressive fluid intake. The amount reported is 2 to 3 liters per meter square or up to 4 liters in an adult throughout 24 hours. You cannot let the patient take that amount just packed in a few hours and remain the rest of the day dehydrated. And even some guidelines recommend monitoring of that intake through following urine concentration, urine specific gravity, and sometimes more sophisticated tests such as crystal size and supersaturation studies in order to monitor that. Of course, that's going to be a problem in patients with advanced CKD who might need or might not tolerate that amount of fluid intake. And in small infants, it has been reported, I know it's difficult to do these things in some cultures, but it has been reported that infants with very early primary hyperoxaluria may benefit from gastrostomy in terms of ensuring a continuous adequate fluid intake together with adequate nutrition, because we need these infants to grow, because it facilitates so much any intervention we're going to do later. So aggressive fluid intake. Crystallization inhibition, we mainly use potassium citrate. Of course, I'm not talking about patients with end stage who might need potassium restriction. Orthophosphate, neutral phosphate has been reported to inhibit crystallization as well. Reduction of dietary oxalate and hydroxyproline intake. What we have been used to do is to say that primary hyperoxaluria, particularly type 1, the source is mainly endogenous, and modifying the diet will have little or no contribution to managing this. However, a relatively recent study in 2018 found that reducing or controlling oxalate and hydroxyproline intake could reduce urinary oxalate excretion by a significant amount, but that's not enough to avoid CKD progression. And of course, dietary restrictions in infants and young children can be difficult given the need for appropriate growth. So it's not the mainstay of therapy because the source is primarily endogenous. There is no need to restrict calcium, and restricting calcium can be a very bad thing to do because restricting calcium can promote oxalate absorption from the GIT and actually increase the amount of oxalate load, because calcium in the diet will bind oxalate and reduce its systemic absorption. Is primary hyperoxaluria a vitamin-dependent condition? Now, what is a vitamin-dependent condition? A vitamin-dependent condition is a condition which is not due to vitamin deficiency, but it can be treated with large doses of a certain vitamin. Now, pyridoxal-phosphate, which is the active form of vitamin B6, is the cofactor for AGT, which is the enzyme whose abnormalities or loss of activity is responsible for type 1 primary hyperoxaluria. And the use of high doses of vitamin B6 may promote enzyme activity and or import to the peroxisomes, and therefore it can reduce endogenous oxalate production. However, this effect depends on the type of mutation. Mutations with complete loss of the enzyme, of course, the cofactor would have no value. And when we say B6 response, it means more than 30% reduction in urinary oxalate. And there are certain mutations that are known to be vitamin B6 responsive. However, guidelines recommend a trial of vitamin B6 with measurement of urinary oxalate before and after in all patients. Vitamin B6 response does not mean that end-stage kidney disease will be prevented. However, it can slow the disease progression. Is there a role of probiotics in primary hyperoxaluria? Now, there are certain bacteria like Oxalobacter formigenes that can metabolize oxalate and use oxalate as a food. So it was thought that if we can give these bacteria, they can metabolize the oxalate in the intestine and they can treat primary hyperoxaluria. The problem, though, is that the main source of oxalate is endogenous, and predictably, this could reduce the amount of oxalate in certain studies, but not by the amount that's going to make it effective in changing the course of a severe form of primary hyperoxaluria. Now, when patients develop end-stage kidney disease, the management is intensive hemodialysis. And we all know it, but what exactly is intensive hemodialysis? Intensive hemodialysis refers to a blood flow of at least 150 to 200 milliliter per minute per meter square body surface area, using a high flux dialyzer with a surface area that exceeds the patient's body surface area, 5 to 7 times per week, 2 to 3 hours each time. And it should be individualized based on the patient's plasma oxalate. If plasma oxalate is very high, but the patient otherwise does not need to start dialysis, it may be beneficial to start dialysis at this phase to avoid the burden of tissue oxalosis. And again, guidelines recommend monitoring plasma oxalate to judge the adequacy of intensive dialysis. However, this treatment has problem with vascular access that you're going to use approximately daily, particularly in a small child. The cost and insurance coverage issues of high flux dialysis at least 5 times per week, and the quality of life issues. And as if this were not enough, some studies suggest supplementary nocturnal peritoneal dialysis. So the patient is going to be on regular hemodialysis and is going to insert a long-term PD catheter and receive peritoneal dialysis at night in the hope that PD with HD are going to clear adequate amount of oxalate, and it doesn't. Still, even intensive hemodialysis should not be thought of as a treatment for end-stage kidney disease due to primary hyperoxaluria, because even no currently known modality of dialysis can remove adequate amounts of oxalate to prevent tissue loads. So this treatment should be regarded as temporary until a more definitive therapy can be done. And therefore, patients with primary hyperoxaluria type 1 and end-stage kidney disease should be transplanted as soon as possible, since no other renal replacement modality is able to remove adequate amount of oxalate. This article has been discussing nephrolithiasis and nephrocalcinosis in childhood, current and future treatment, and they only mention transplantation in one disease, which is primary hyperoxaluria. Liver transplantation. Now, for type 1 primary hyperoxaluria, the only current definitive cure is total removal of the native liver and liver transplantation. And total removal is very important because given surgical circumstances, sometimes surgeons are going to accidentally or over difficulties leave parts of the patient's native liver and would successfully transplant a new liver. Now, note the problem here is not that the patient is suffering from liver failure, it's that the liver is the seat of production of excessive amounts of oxalate, so leaving any part of the native liver should not be tolerated. The problem is sometimes doing a liver transplantation in someone without liver failure, and acceptance of this by the patients and their parents, especially in absence of a deceased donor program, poses difficulty in suggesting liver transplantation routinely for type 1 primary hyperoxaluria. We've done it, but there are many difficulties in that. Okay, kidney transplantation. Now, for type 1 primary hyperoxaluria, isolated kidney transplantation is not recommended. Some suggestions يعني على استحياء كده are talking about B6 responsive cases with surgical risk, because as we know, kidney transplantation is a less extensive surgical procedure than liver transplantation. Type 2 primary hyperoxaluria frequently, not frequently because not many of them reach end-stage kidney disease, but isolated kidney transplantation could be an option there. For type 1 primary hyperoxaluria, liver transplantation is the only definitive cure, and therefore, when the patient has advanced CKD, we can do either liver transplantation and wait for kidney transplantation later, which is called sequential liver kidney transplantation, or they can be done at the same setting, simultaneous liver kidney transplantation, as it was done with our first patient we started the presentation with. Of course, simultaneous liver kidney transplantation is a very extensive procedure, usually requires 2 donors, although it has been done from 1 donor in young patients who require only a left lobe of the liver. Simultaneous liver kidney transplantation will not require a future major surgery, and if the kidney graft functions immediately, we will not face difficulties with perioperative dialysis when doing liver transplantation in a patient with primary hyperoxaluria and kidney failure. However, if there is a very high tissue oxalate load, simultaneous liver kidney transplantation would mean that the graft will have to excrete that oxalate load, and excreting that oxalate load could initiate another cycle of hyperoxaluria, oxalate deposits, which is not due to recurrence, but due to oxalate mobilized from the bone, the cardiovascular system, and the other organs of the recipients. Sequential liver kidney transplantation may be a less extensive procedure than combined, and transplanting a liver first could mitigate the tissue oxalate load in addition to dialysis. So the liver graft will not produce excessive oxalate, and the intensive dialysis would remove the load already present for a kidney transplantation later, and intervals reported have ranged from 3 to 6 to 12 months in order to optimize the survival for the renal graft. Also, theoretically, we might think that if we do a liver transplantation preemptive with normal or early CKD, maybe the patients might not require kidney transplantation in the future. No guideline has explicitly stated that simultaneous is better, sequential is better. It all depends on individual patients, center experience, availability, and possibly tissue oxalate load that's present. The management, we've talked about conservative measures, fluids, vitamin B6, possible role for probiotics, crystallization inhibitors, urological interventions if the stones would cause any complications, renal replacement, and we have said that early transplantation is the best because dialysis is not enough, liver transplantation to avoid the source of oxalate. As we can see, all options are quite aggressive and can have bad effects on patient quality of life. And that's why novel and emerging therapies exist. Now, this is the pathway for primary hyperoxaluria type 1, where we have the AGT enzyme with the red X sign there. We have glycolate converted by glycolate oxidase, which I told you about early in the presentation, to glyoxylate, which is the precursor of oxalate when it cannot be converted to glycine due to AGT mutation. Now, what they thought of is, what if we block the preceding enzyme, the glycolate oxidase? So glycolate will accumulate, but will not be converted to glyoxylate, and therefore there will be no excess oxalate. A substance called lumasiran has been developed to block the glycolate to glyoxylate conversion through stopping the effect of glyoxylate oxidase. We will see now how that was done. That was done using something called siRNA. siRNA is silencing RNA, is short or small interfering RNA, which is a short double-stranded RNA that when it enters the liver cells, it has been formulated to go to the liver cells where that enzyme is present, and it activates an RNA-induced silencing complex that can cause what we can call post-transcriptional gene silencing. The gene is there, but it's going to stop the production and activity of the enzyme, and therefore we are going to have this GO, glycosylate oxidase, not active. We will have no excess glycosylate and no excess oxalate, and the oxalate will be reduced in the urine, reduced in the tissues, and this could be a good treatment for these patients. Now, this drug has been tested in the Illuminati trials. There are 3 up till now. The Illuminati B phase 3 trial with lumasiran has reduced urinary oxalate excretion by 72% in patients with primary hyperoxaluria, including children older than 6 years, but the trial only included those with a GFR more than 30. They did not include those with CKD4 and 5. But they could demonstrate that this drug reduced urinary oxalate by 72% in these patients, and this data were reported in the year 2020. And as a result, both the EMA and the FDA have given approvals before the end of 2020 for this substance as an orphan drug and as the first of its kind, the silencing RNA-based therapies. And the Illuminati C trial is currently testing the use of lumasiran in those with end-stage kidney disease, obviously not with the goal of reversing the end-stage kidney disease, but with the possible goal of reducing oxalate synthesis, oxalate tissue load, and the subsequent need for liver transplantation. And this is the drug. This is the lumasiran. It's now present under the trade name Oxlumo, and the dose of this drug is 3 milligram per kilogram for patients above 20 kilos and 6 milligram per kilogram in children under 20 kilos. And it has been used in the trial initially monthly, and urine oxalate levels near normal have been achieved after 3 months. The protocol suggested is a follow-up dose every 3 months after the first 3 months, and it's just a subcutaneous injection. It's a subcutaneous injection, 3 monthly doses, and then a dose every 3 months. However, this drug currently costs between $60,000 and $90,000 per vial. The other idea was to stop this number 5, remember, the step of conversion of glyoxylate to oxalate targeting LDH. This diagram shows the different therapeutics for primary hyperoxaluria. LDH targeting in the top right of the slide. There are 2 drugs currently in trials, nedosiran and stiripentol, for their potential role in blocking the final conversion to oxalate. The use of the enzyme, not the bacteria, but the enzyme oxalate decarboxylase. We don't have this enzyme in our body, but bacterial and fungal organisms do, and there are trials with preparations of the oxalate decarboxylase for its potential to reduce the oxalate by metabolizing it further. The use of chaperones, which are small molecules that can cause a favorable enzyme conformation to prevent its inactivation or degradation, and this can be of value in certain but not all mutations like pyridoxine and betaine. Enzyme restoration therapy is another potentially experimental therapy by using technologies related to messenger RNA cell transplantation, CRISPR technology, to restore the enzyme activity of the AGT. And lastly, targeting the inflammation. Remember when we said that oxalate has tubular toxicity and causes inflammation and progression of CKD? Maybe if we target this, we can leave the oxalate high but mitigate its damage. All these are currently experimental approaches. Whether we know lumasiran is now approved as an orphan drug. Several others are in trial phases, and those on the left side targeting enzyme restoration and inflammasome are currently in preclinical trials, in non-human studies yet. And this is from Shi and Stoller, who published this in 2022, just last year. And many of the things which I've said that the guidelines recommend or do not recommend, many of them are from this source, the clinical practice recommendation for primary hyperoxaluria from ERKNet and Oxal Europe, and this has been published this month in March 2023. The story of primary hyperoxaluria is a story from don't eat oxalate through enteric hyperoxaluria from the GIT to a genetic metabolic disorder, as Professor Ahmed has said in the introduction. It is a genetic metabolic disorder affecting the kidney. It's a story of awareness. We must think of this disorder, of testing, and now utilization of genetic testing to diagnose or confirm the disorder. It's a story of tailored renal replacement therapy when needed. It's a story of precision medicine, starting with Oxlumo and many others in the pipeline. It's a story of a devastating disease that does not have to remain so, and thank you.
Thank you, Professor Hafez, for this highly demonstrative and comprehensive lecture. Professor Fatina and Professor Ahmed. Professor Ahmed?
Yes, thanks, Professor Hafez. Really, very much interesting and
Yes,
very well said,
really.
very well delivered, very well gathered. I was really enjoying a fascinating movie that have been very well executed. I mean, you've gone through the disease spectrum from the very early beginning to the very end of the state of art and the edge in the management, and really many potentials are there, and you have enlightened all of them. Thanks for the very enlightening lecture, Professor Hafez.
Totally
Thank you.
agree with you, Professor Ahmed. Totally
Yeah,
agree,
thank
Professor Fit.
Professor Hafez. Yeah, it's very illustrative and informative lecture, and it was like a journey through the hyperoxaluria. So thank you very much for this fantastic, really, presentation.
It's really the first time for me to hear this difficult topic in such very simple, smart way, and very comprehensive and inclusive for all information. Thank you, Professor Hafez, really. Let we start discussion.
Yes.
Okay, so we will start
Dr.
with the
Khaled
floor. Yes, تفضل.
Dr. Khaled Abu Zaid, not standardized, high cutoff range not detected if GFR more than 30, oxalemia and oxalate serum level lab test have significance or impact in the diagnosis and the follow-up. Please write your question, Professor Khaled. I think he is summarizing the information or something like this, Dr. Khaled.
Okay, what I think we need to throw a bit of light about is the limitations of plasma oxalate. And basically, plasma oxalate, we cannot rely on urinary oxalate excretion when the patient has reached an advanced stage of CKD. Okay, and by this stage, oxalate will start to accumulate in the plasma, and that's the issue of oxalosis. Plasma oxalate has several problems because the reported cutoffs in the literature are highly variable, apparently depending on the test technique and also on the extent of renal dysfunction, because patients with advanced CKD without primary hyperoxaluria can have increase in plasma oxalate levels to some extent because its main excretion is through the kidney. So the test has been used to screen or confirm the diagnosis of primary hyperoxaluria in patients with significant or advanced CKD. We have many difficulties with this test. I think Professor Fatina will agree with me about that. It's sometimes available, sometimes not. Sometimes we get conflicting results. Sometimes we send samples to other countries and get totally different results. So it's a test that still needs further standardization. And it needs correction for the level of renal impairment. I guess that's what the question was about. Monitoring treatment with urine oxalate, we can remember together that the early trials with Oxlumo have been with patients with relatively preserved renal function. So the endpoint is reduction of urinary oxalate, which is a surrogate marker for reduction of CKD progression and the need for transplantation later on.
Professor Faisal
there was a question again. What do you mean by adequate calcium intake regarding the adequate oral calcium intake to decrease the load of oxalate by the gut?
I mean that there is no need to restrict calcium, because we might inadvertently think that the deposits are calcium oxalate, and therefore we should ask the patients to restrict dietary intake of calcium. So what I mean is that restricting dietary calcium can conversely increase oxalate absorption and cause some form of enteric hyperoxaluria. So restricting oxalate intake in type 1 primary hyperoxaluria has very little effect, but decreasing calcium can have a negative effect. So patients should take normal amounts of calcium.
Yes, but there's no need. There is no need for calcium supplementation. I mean, as calcium pills.
Calcium supplementation has not been explicitly recommended, except perhaps in the context of advanced CKD as a phosphate binder or something like that. But I haven't come across a guideline that directly stated give calcium supplements to reduce enteric oxalate in patients with primary hyperoxaluria.
Yes.
But there is no need. There is no need to restrict calcium. That's what has been stated clearly.
Okay.
Lumasiran follow-up, still by serum oxalate level?
By urine oxalate.
Urine oxalate.
Yes.
Okay. Faisal Shaheen?
Yes, thank you. Thank you, Prof. Yes. Yeah, this is excellent talk. Actually, very well given, and it covered everything, even the new insight. And I like what you mentioned about transplantation and the possibility to transplant such patient with follow-up. But I don't know, I don't come across about the long-term follow-up of such patients. How, according to the 3 types which you mentioned, which one we can go ahead and do transplant, and we think that the outcome is excellent, better than the other? Okay.
Okay. In pediatric nephrology, we are so much more concerned about type 1 primary hyperoxaluria. And many times we say primary hyperoxaluria when we mean type 1 primary hyperoxaluria. Type 2 and type 3 are less severe forms usually.
Okay.
And based on that, type 2 primary hyperoxaluria who develop end-stage kidney disease have received isolated kidney transplants with a recurrence risk much less than the type 1 patients. Most of type 3 do not reach end-stage kidney disease, and transplantation reports, follow-up post-transplantation reports of type 3 are very limited as far as I can find them.
Okay.
So type 1 is the most common and unfortunately the most severe. Type 2 can reach end stage, but in a relative minority of patients. And type 3, the problem is mainly related to stones and nephrocalcinosis rather than progressive CKD.
And all of them can have combined liver and kidney transplant. We cannot with kidney only, isn't it?
Isolated kidney transplant with type 1 primary hyperoxaluria has an unacceptably high recurrence risk. Although maybe with the new treatments, this could change.
Okay, thank you, Prof.
Isolated kidney transplant has been done in type 2 patients. It has been done.
Fine.
Okay, Professor Hafez, we have a couple of questions related to the genetic testing of the primary hyperoxaluria, and both questions are just wondering about whether you test for a single gene or for a small gene panel or for a whole exome sequencing, which I think is not indicated in cases of primary hyperoxaluria. So how do you put that forward in a cost-effective way to be tested?
As pediatric nephrologists, we usually test for type 1 or mutations, AGT mutations. Type 2 and type 3 can be tested, but to the best of my knowledge, are not commercially available in Egypt. So if you need to go beyond type 1, you will unfortunately have to do a whole exome sequencing, which I agree with you that it is not needed if the whole panel is available. But we have the type 1 alone. We can test for type 1 primary hyperoxaluria per se. Maybe our professors in adult nephrology who see more cases of type 2 and type 3 could tell us whether the tests are available as single gene tests or as a panel of the 3 mutations on a commercial, not a research basis in our country. I'm not sure of that. But I'm sure that type 1 is available to be tested separately, and that's what we do as pediatric nephrologists.
Actually, Professor Hafez, they are available, but unfortunately, you have to send them abroad, and they would cost like $600 to test for the whole panel, small panel of the primary hyperoxaluria with the whole gene set. And it would take like 6 weeks to get back with the results.
6 weeks is not, but the cost may be a bit higher than a whole exome sequencing done in Egypt. So scientifically, you don't need it, but maybe if you're suspecting something other than type 1, I mean, it's going to depend on the logistics. But if everything is available on a purely scientific basis, you can test for all 3 mutations, and you don't need anything else because we know them, we know where they are. We can do a targeted gene sequencing for those 3 types we know, type 1, type 2, and type 3 primary hyperoxaluria. So technically, we don't need the whole exome sequencing, but the question of availability and cost is another issue.
Yeah, thank you.
I think, excuse me, Professor Hafez, I think if we go for whole exome sequencing, it will, yeah, I think it will diagnose the case, and the cost will be less than doing the gene detection by Sanger technique for the 3 genes which are more common to be tested. And we might at the end we might not reach the diagnosis and go again for whole exome sequencing. So why not to go from the beginning for whole exome sequencing to reach the diagnosis? And actually some cases, because you are suspecting primary hyperoxaluria and it might be another condition. Actually, we had a patient who presented with nephrocalcinosis and stone formation and so on. And we were testing for primary hyperoxaluria, and we went for genetic study by panel testing. And after that, we went for whole exome sequencing, and it was proved to be familiar hypomagnesemia, hypercalciuria, and she went for kidney transplantation, not combined liver kidney transplantation, and it was totally different diagnosis. So I think whole exome sequencing from the beginning, if it is available, and I think the cost is less than testing for the 3 genes. So I would recommend to do whole exome sequencing from the beginning. What do you think about this?
Well, it all depends on why we are testing. AGXT1 is available alone at a cost slightly less than whole exome sequencing, not a lot. So if we're looking to rule that out, we can do it alone. Doing all 3, as you said, Professor Fatina, doing all 3 in Egypt now costs more than a whole exome sequencing. But definitely, if we're not looking specifically to rule out type 1 primary hyperoxaluria, and we are expecting that we might have other findings or other explanations for the condition, then definitely a whole exome sequencing could help. Some guidelines have guided the testing using oxalate metabolite assays in urine. I mean, we can measure glycolate and the oxalate pathway metabolites in urine, and then that's what they say in the guidelines. The oxalate metabolites are not easily available, of course, but they sometimes say that if we do the profile, we can expect which one and just do that one. But again, the problem, if it's negative, we have not excluded primary hyperoxaluria. So unless we're talking specifically of type 1 primary hyperoxaluria, whole exome could be necessary given the circumstances you have just elaborated. It depends on what we're looking at.
There is a question here that Dr.
Professor
Muhammad Adel. Yes.
Excuse me, Professor Saeed Khamis is waiting for us.
Okay.
Before we go to this question, Professor Saeed.
Good evening, professors. Thank you, Professor Yasser. Thank you, Professor Hafez, for this elegant presentation. I have 3 short questions. Number one is, few days ago, there was a published article in nephrology dialysis transplantation showing that a plasma glycolate in dialysis patient with and without primary hyperoxaluria is more useful in diagnosis of this illness, or I mean primary hyperoxaluria type 1, than plasma oxalate. So this is the first question. What is your comment on this?
It is glycolate is a marker for type 1, and it has been used in urine as a step before doing the genetic testing, if available. In plasma, it seems a promising step, but I don't think it's available in Egypt. But I'm sorry, I didn't have the opportunity to read that particular article. But it could be, yes, it could be a marker for type 1 hyperoxaluria, primary hyperoxaluria, given the metabolic pathway itself leading to the cause. It could be promising. It could be promising, but we don't have it now. But again, it's going to be very specific to type 1.
Yeah, for sure. Second one is regarding bariatric surgery. You know, nowadays there is a row for this bariatric surgery in obese young girls, and so especially the raw NY, not the sleeve one. And consequently, you know that oxalate stones are there. The question is for you and for Professor Fatina and Professor Qorai, especially in adult patients. Do you see many patients develop oxalate stone actually after this raw NY surgery?
I think Professor Qorai could answer this better than me.
Okay, thank you. Actually, I have counted 2 cases with bariatric surgery, and both suffered from stones. And I think all bariatric surgeons are advising those patients that they are very potential to develop kidney stones, as well as gallstones, as you know, and even most of them now do cholecystectomy during the operation, or just before or just after, because of the instance of more gallstones occurrence. As regarding the kidney stones, hydration could be a good solution, and maintaining a good fluid balance for those patients, and follow up by ultrasound on basis of like every 6 months interval, and be very having very low threshold for any loin pain or difficulty in micturition or manifestation of UTI or so. But I think it's not totally preventable, and it's something that have to be paid for such operations.
Okay, thank you, Prof.
I know I shouldn't be asking, but would you consider potassium citrate in these patients?
Well, the issue is if we have to try to dissolve these oxalate or prevent their formation, I think maybe magnesium sulfate would be magnesium citrate, I mean, would be a better option than potassium citrate. We use usually potassium citrate more with the urate stones rather than with the oxalate 1. But again, the problem with those patients that they cannot tolerate such powder or effervescent therapies, and mostly if they do with the plain water, it would be very nice for them actually.
Particularly
Okay,
in early stages, yes.
yeah. Last question is, thank you, Professor Ahmed. Last question is regarding the Lumiziran. This Lumiziran, despite it is expensive, I know, can mitigate our need for liver kidney transplantation currently, or at least in the near future?
Well, the trial that has been concluded and presented and led to FDA and EMA recognition as an orphan drug for Lumasiran has only included patients with a GFR above 30. And their endpoint has been reduction in urinary oxalate excretion. But the natural next step would be that patients will need to be followed for CKD progression, and I guess that needs more time. And patients with advanced CKD who could need renal replacement and receive the drug, what we expect and what we hope for, that it's going to replace liver transplantation in the management. I mean, patients can receive the drug and receive just a renal transplantation without a liver transplantation. But the Illuminati-C trial on patients with advanced CKD, to the best of my knowledge, they have completed enrollment, but results are not yet there. So I guess it just needs more time to be certain about that.
Okay, thank you, Professor. Thank you so much.
Thank you.
Okay, we're back to Dr. Muhammad Adil, who was asking about a case that had renal stones and was thought to be AGXT proved, but with testing specific gene, the case was proved to be negative. With the whole exome, it turned out to be FSGS. So what do you think about I mean, Professor Fatina earlier pointed to a case of probably Claudin 16 or Claudin 19 with the hypomagnesemia, hypercalciuria, and nephrocalcinosis. We can see this in medullary cystic disease as well. Maybe sponge kidneys, yes. But with FSGS, I would like to, it's very interesting, and I would like to hear from you in pediatric nephrology. Do you see steroid resistant nephrotic syndrome with a picture of nephrocalcinosis?
Basically, if AGXT1 is normal, it's not type 1 primary hyperoxaluria.
Okay.
This patient likely had end-stage kidney disease, and FSGS or I mean podocytopathy associated mutations in the whole exome. That's what Professor Fatina was just talking about, is that sometimes we find other things than what we have been looking for. Many times we have found collagen mutations associated with Alport in patients with steroid-resistant nephrotic syndrome. So it's likely that with widespread whole exome sequencing, maybe new things would arise. But I don't think there is a direct connection between FSGS and kidney stones and nephrocalcinosis. And maybe I'll ask Professor Fatina if she has encountered something like that before. Or
no, I think if this FSGS is detected by renal biopsy or
No, by whole exome sequencing.
By whole exome sequencing, what is the gene mutation?
It's not written in the question, actually.
Diagnosis. FSGS is a clinical pathological diagnosis. So if this FSGS is detected by renal biopsy and pathology, this would be secondary. But if it's a genetic diagnosis. There's no genetic diagnosis under the name of FHGS. What is the gene mutation detected by the genetic study? Whether whole exome or what? A whole exome, I think. What is the gene?
Mutations like for example NPHS2 or ACTL.
NPHS, yes. Yes.
We have to find by whole exome sequencing. We have a gene mutation. What is this gene mutation? We don't have a diagnosis of FHGS in the genetic study. This is a pathological diagnosis. So it would be a secondary FHGS, as Professor Hafez have.
He added one added to the question.
Disease secondary.
Yeah, he added that it's NPHS2 gene mutation.
Yes, yes. So it's proven NPHS2 gene mutation, and the pathology is FHGS. If the patient has oxalate deposit, this would be secondary, not the primary diagnosis, I think.
But
is it easy to have two?
Yes.
Is it easy to have two genetic mutations at the same time?
No, it was negative, Dr. Yasser, for the AGXT XT. So the question is,
yes, it's negative for the GXT. That's what I understood.
And the question here is, do you often see with patients with resistant nephrotic syndrome any type of secondary oxaluria or oxalate stones or anything like this in your because we don't see that in adult age group. So is it common in infants or on children? I mean,
no. If the patient goes in end-stage renal disease, we might find some oxalate deposits in the biopsy and secondary, not so frequent, of course.
Tubulointerstitial oxalate deposits in patients with advanced CKD can be found, but stones and nephrocalcinosis with podocin or NPHS2 mutations is not something I would think is common. And I guess this patient has been tested prior to transplantation. You know, NPHS2 mutations usually have a good outcome following transplantation, and it's definitely not a case of type 1 primary hyperoxaluria if AGXT1 is negative, provided we're trusting the results, of course.
Yes, I think the point that Dr. Muhammad wanted to mention that you can find something totally unexpected. So he's favoring Wes instead of doing gene panel.
Well, that patient benefited from it because while we were looking about a potential problem with transplantation, what we found, if it's FSGS and NPHS2, well, they usually do well after transplantation, unlike sporadic FSGS.
Okay,
so that may have benefited from whole exome.
I'll go for a basic, relatively basic question. Professor Hafez, how do you feel about if you have a positive Wes result for a genetic testing that fits into the phenotype that you have? Basic genetic literature would recommend for proving or approving the finding by Sagner. Do you do Sagner in such situation, or you because it would be an added cost, or you just accept the Wes result and no more adding tests?
For the most common everyday practice situations, we don't.
Okay.
If it's the expected finding, and I mean, if a patient is clinically primary hyperoxaluria, and it well, probably we won't do it. But yes, okay, that's recommended sometimes, or that's usually stated as the best practice to confirm the abnormality, but we don't routinely do that now.
Unfortunately, I had like 3 or 4 patients that have tested for potential C3 glomerulopathies, and 2 of them at least had a variant of undetermined significance that you cannot rely on to say whether or not this is typical for the phenotype they have. So you needed to do Sagner afterwards to find out whether this is accepted or not.
Well, in that case, definitely so. But if the finding is typical with what we're looking for, that's another issue. I mean, variants of uncertain significance is a totally different issue than confirming a clinical or a phenotypic condition with an expected genetic finding.
Okay. Okay.
At least that's what we do. If it is a variant, as you've said, that's another issue, of course, that needs further elaboration, and we can just take it, and we cannot just take it as the cause of the condition, which doesn't really fit. However, if it's typical, I mean, most of the time we don't routinely do a Sanger sequence.
Okay. Okay. Any more questions from?
I have no more questions. No more comments and no more questions, and I think it's time to close.
Okay.
Professor
Okay, it was very.
Thank you. Thank you.
Thank you very much, Professor Yasser, for choosing this very important topic to be presented tonight. Thank you, Professor Farai, for sharing, moderating this very important talk. And thank you very much, Professor Hafez, for preparing and presenting this very important and very informative presentation. Thank you.
Thank you, Professor Fatina. Thank you, my dear professors and colleagues.
Thank you.
Thanks, Professor Hafez. Thanks, Professor Yasser. Thanks, Professor Fatina. It was very, very nice and interesting night, and a lot of information added to our knowledge, and hopefully, inshallah, to our practice to help all patients in adult and pediatric. And looking forward, Professor Yasser, for more multidisciplinary approach with the nephrology, pediatric nephrology. Really, we need it. We have been taught a lot from them tonight.
And we expect all to be such interesting as this session.
Thank you.
Thank you, Professor Hafez. Thank you, Professor Hafez, for this really very, very, very interesting lecture and your response to the discussion in a highly scientific and informative, summarizing way. Thank you, Professor Ahmed for sharing in the discussion and stimulating discussions and questions, and stimulating Professor Hafez to give more and more and more information. Thank you for Professor Fatina for sharing us with your great experiences both in pediatric nephrology, which helps us usually in our deal with cases transition from pediatric to adult nephrology. And this session was in extreme harmony between pediatric and adult nephrology, and we enjoyed much. And as Professor Ahmed said, we expect to have more and more collaboration with pediatric nephrology, with adult nephrology sessions to share in improving outcome and clinical practice with our patients. Thank you all, and excuse me to close. Our coming session, we will stop next week for Ramadan. كل سنة وحضراتكم طيبين will be the first of Ramadan, or the first night of Ramadan. كل سنة وحضراتكم طيبين, and we will resume our وحضرتك طيب, كل حضراتكم طيبين. We resume our sessions again in 2 weeks after by clinical forum, ESMT clinical forum by Tanta University, will be presented by Tanta University, and our usual time will be shifted 1 hour later at 10 p.m. in Ramadan, inshallah. Thank you all. تصبحوا على خير
Thank
والسلام
you.
عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
شكرا
جزاكم الله
جزيلا.
خير.
شكرا